I'd like to thank the SFAR committee for having me today. I'm really honored to be here with Professors Cecconi and Leon. And today's topic is about fluid deresuscitation, also called DRES in ICU patients. I have no conflict of interest to declare. Fluid management is challenging in clinical practice because patients are dynamic and they are going through different phases. To put this in perspective, the ROSE concept highlights the time course of fluid administration, and we will focus on the last part of this diagram, the evacuation or deresuscitation, also called DRES. This concept may be well applicable to all of your ICU patients, but it has mainly been described for ARDS and septic shock patients. So there has been a number of randomized controlled trials regarding the early phase of fluid resuscitation. However, there are only a few studies dealing with the evacuation of fluid. So why is the DRES so important in clinical practice? You may all be familiar with this picture, the Michelin Man. Fluid in excess is not only a cosmetic issue because it is associated with a lot of organ dysfunctions, such as respiratory complications with increased need for oxygen, delayed weaning, or extubation failure, but also acute kidney injury or visceral complications, all associated with worse outcome. And this is what has been underlined in this meta-analysis. A positive fluid balance and fluid overload have been consistently associated with an increased risk of mortality. But does it mean that DRES leads to better outcomes? Well, yes and no. In this meta-analysis, the DRES was not associated with a significant decrease in mortality, but only a trend too. But some of the important outcomes that we are looking for in clinical practice, such as the ICU length of stay or the duration of mechanical ventilation, were achieved. So late conservative fluid management and DRES are encouraged by these observations. So one of the main questions of this lecture is how to tackle DRES, and it starts with when to start DRES. Obviously, there is no good answer and neither not much evidence so far. DRES has to be considered as an ongoing process as part of the late conservative fluid management. There may be major discrepancies between physicians about when to start DRES, and this has been underscored in this survey involving critical care physicians from the UK. Marked practice variability was evident among respondents, and one of the main results is that 85% believed fluid overload to be a modifiable source of morbidity. The authors also evidence that in a given clinical scenario, self-reported practice range from the administration of fluid bolus to the administration of diuretics, which is a bit contradictory. However, the majority agreed on the use of diuretics in the setting of noradrenaline infusion and despite mild electrolyte disturbances. The first step of DRES is actually to acknowledge that you as a physician are giving unwanted fluids. Erine, the authors retrospectively analyzed every fluid source administered to their patients, and one of the striking results of this study is the amount of fluid creep administered, representing as much as 1/3 of the mean daily total fluid volume. And this is really substantial. But the good thing is that there is a large room for improvement just by paying attention to what we prescribe and how it is administered. So if you don't really know when to start DRES, at least you can get rid of the unwanted. In the quest for the optimal timing, and if I summarize the design of different studies, DRS was started very early in RDS patients, 48 hours after ICU admission, or as soon as shock resolution was obtained, defined as being free of vasopressors for at least 12 hours with a mean arterial pressure greater than 60 millimeters of mercury. It can even be started earlier as part of the stabilization phase. Erine, the authors, examined the effects of early restrictive fluid resuscitation after the initial resuscitation of a septic shock. In the restrictive group, fluid boluses were allowed only in case of severe hypoperfusion, and the criteria were pretty stringent. The cumulative fluid volumes at day 5 and during the ICU stay were significantly lower in the restrictive group without causing ischemic events or worsening of acute kidney injury. But some questions on the timing remain to be elucidated. For instance, should I put my patient on diuretics while he's still on vasopressors? So are there any useful tools to determine when to start? In this study published in the Blue Journal, which is a bit different from the others dealing with fluid management, the authors hypothesized that a BNP-driven protocol to guide DRS would improve successful weaning. As you can see, the BNP levels were greater than 200, but not that much elevated. The intervention group was, of course, aware of that levels. In this group, furosemide and acetazolamide were given more often and in higher doses than in the control group, resulting in a more negative median fluid balance during weaning and more successful weaning. One of the keys to successful deresuscitation is not starting when the intravascular volume is not in euvolemia, because it carries additional risks of secondary organ failure, such as precipitating an acute kidney injury, for instance. High CVP was used in the FACT trial to start DRS, but this algorithm was quite complex and it has been simplified afterwards. But still, CVP may bring some useful information about the volume status. As part of the numerous parameters provided by the transpulmonary thermodilution technique, the extravascular lung water index may give the clinician a measurement of fluid accumulation within the lungs. And this could well be a trigger for starting DRS. However, it is difficult to apply in clinical practice and to all of your patients because it is time-consuming and also resource-consuming. Moreover, it takes 4 to 5 days to show a difference. Bioelectrical impedance is a technique known for a while now and provides details on fluid status. A new device has come to the market lately, and it allows to calculate fluid excess, but also fluid underload and body fluid compartments. It may be an interesting tool, but whether it is useful for the management of the DRS process remains to be proven. With colleagues of mine from Amsterdam, we wondered if the DRS phase could be monitored in another way. So we looked at microcirculatory parameters of cardiac surgery patients discharged from the ICU. And we observed a progressive recruitment of the microcirculation while the patient was on diuretics. These results paved the way towards a new method for the management of fluid duress and helps the clinician differentiate between convective or diffusive alterations within the microcirculation. Now the question, how to duress. In this very recently published French pragmatic study, the authors assessed the efficacy of furosemide on the weight loss considered as a surrogate of fluid balance and fluid overload. Furosemide was indeed efficient without, unfortunately, significant effects on mechanical ventilation duration, ICU length of stay, or mortality. However, less worsening of acute kidney injury was observed in the intervention group. Other diuretics have been used in different clinical trials, but furosemide remains the easiest to manage. The administration of small boluses and the titration are the most frequently reported mode of administration. Some studies investigated the role of albumin, and in this randomized controlled trial, the authors compared two strategies of fluid duress using furosemide in patients with acute lung injury. In one group, they infused albumin in addition to furosemide, and 24 hours later, the PF ratio improved significantly compared with furosemide alone, with a greater negative fluid balance. On top of furosemide and albumin infusion, Cordemans and colleagues investigated the effects of a high PEEP in similar patients. The results were consistent with the previous study, although it was not a randomized controlled trial. Of note, the control group suffered an astonishing mortality rate of 50% compared with 28% in the intervention group. So are there any safety issues related to duress? Well, acute kidney injury and electrolytes disorders are among the most feared complications. But if we compile the results of different studies aforementioned, only minor electrolyte imbalance such as hypokalemia or hypernatremia were observed without an increased rate of acute kidney injury or renal replacement therapy. These observations were, however, not confirmed in the recent IRIS study by Sinotti. So diuretics may be of benefit, but what if my patient does not respond to diuretics? Well, this is a serious issue. Of course, the duress process can be supported with the use of renal replacement therapy. Unfortunately, if we look at the results of these large RCTs, the only thing that we want to do is actually wait and see. But on the contrary, if we dive into the data of these patients, a lot of them were not fluid overloaded. So here is the suggestion on when and in whom to use renal replacement therapy. The ELANE study found benefits of early renal replacement therapy, maybe because included patients were mostly cardiac surgery patients with a positive fluid balance of at least 6 liters. And indeed, 75% had fluid overload. We are looking for the publication of the RADAR 2 trial, which results have been partially presented on criticalcarereviews.com. There may be safety concerns in the sepsis subgroup, but it may be secondary to the imbalance in randomization. The results of a larger trial led by Anders Perner, including more than 100 patients, is awaited later this year. So the take-home message, first you need to acknowledge positive fluid balance and fluid overload. And to do that, you need to assess and quantify fluids every day, but also weigh your patients. You have to pay attention to the unwanted fluids given. This is pretty easy, and fluid creep is really beyond your eyes. Start DRS as soon as possible at shock resolution, definitely. And the DRS process is really, really useful for patients with acute lung injury and RDS or septic shock, because you have to let the lungs on the dry side. Finally, furosemide will only manage urine volume, but it does not prevent or cause acute kidney injury. Central venous pressure may be a useful tool to start DRS, and you should definitely go for a personalized medicine and titrate furosemide based on the medical history of each patient. Last point, to avoid fluid accumulation, you probably need to increase PEEP, stop sedation early, and facilitate early mobilization of your patients. I would like to thank the audience for having me today.
Thank you very much, Philippe, for this excellent talk. So we don't have a question from the audience, so I will start, and I would like to know how do you implement DRS in your unit? Do you have a protocol? Do you use CVP? Which tools?
So actually, now we don't have a protocol, but I think that every unit should write a protocol on DRS. So because of the COVID period right now, we are really focusing on the weight gain of each patient, and we go for diuretics when the chest X-ray is getting worse, and if there is a weight gain, mostly. But we should definitely go for a protocol. The hard thing with the measurement of the central venous pressure is actually that now we are putting a lot of PEEP on our patients. Yeah. It's mostly 15 centimeters of water. So it has, of course, an influence of the measurement of the central venous pressure. And we don't really want to subtract the PEEP just for a CVP measurement. So this is part of a problem, probably.
Thank you. Do you think there's a place for echocardiography to limit fluid administrations? Because I think you talked about extravascular lung water, and I think there's a way to assess extravascular lung water with echocardiography and lung ultrasound. So it could be a way to DRS.
Yeah, for sure, it's a good point. Again, the problem with the echo is that you can't really make the difference between what is really water accumulation in the lungs from the initial disease, especially in COVID patients. It's always a lot of B lines. You increase PEEP, and basically you don't really know if the disease is getting better or if you remove some water, and I think that's the main issue of monitoring with echo. But of course, it can be a tool, yes. But I think today there is no data about fluid DRS and the echo.
No, I confirm. Mark, do you have questions?
First, thank you for your talk. That was great and very clear, and I agree with your conclusion. We have a lot of data on the association between fluid overload and poor outcome, and we should. I think that the first step is to monitor that very carefully at the bedside every day to know how many fluid intake and how many fluid outtake, and that's very important because when we have the number, we can see the accumulation of fluid. I'm relatively careful on the result of randomized clinical trial, and I'm have interest in the last you show, because I think that if there is an association and the patient receiving more and more fluid are the more severe. There is no doubt. And I'm not sure that giving diuretics and reducing fluid will change the outcome in this patient, and we really need to be very careful. I really be very stringent on the use of fluid at the last late phase of ICU. After 24 hours, I think. After 24 hours, we should be very careful. We should monitor that. But today, I'm not sure that randomized clinical trial could show in the future that very strict attitude with the use of diuretics will be positive. I'm not sure.
So it will be the results of the classic trial led by Perner.
Yes, we'll see. Let's see. Thank you very much.